I would now like to look at hypotension, low blood pressure, and the three major cardiovascular factors that can lead to it. Now first, what is the definition of hypotension or low blood pressure? We will define it as a systemic arterial blood pressure less than 90/60. Now the danger of a drop in blood pressure is it leads to a drop in blood flow, or what's also called blood perfusion, to the tissues of the body. So a drop in blood pressure leads to a drop or decreased blood flow or blood perfusion of oxygen and nutrients to a tissue. This is also known as circulatory shock. While there are other causes of circulatory shock besides a drop in blood pressure, I'm going to use the terms hypotension and circulatory shock together. So let's now consider what are the three major cardiovascular factors that can lead to a drop in blood pressure, which in turn will lead to circulatory shock. If we return back to our diagram on page 255, and on page 255, at the very bottom, it says arterial blood pressure. And we have learned that the two major factors that determine our systemic arterial blood pressure are the cardiac output and the total peripheral resistance. Here you can see that's shown right here. So we're going to be talking about how blood pressure can drop if there is a drop in cardiac output, a decrease in cardiac output, and arterial blood pressure can also decrease if there is a drop or decrease in total peripheral resistance. The third factor that we're going to look at is shown right up here at the top, and that's the blood volume, because the blood volume affects venous return and it affects ultimately the arterial blood pressure. So returning back to page 266, here we've reminded you, that the mean arterial blood pressure is determined by two major factors, the cardiac output and total peripheral resistance. So if either one of those, or both, were to decrease or drop, that would lead to a corresponding drop in arterial blood pressure. So let's first consider if there's a drop in cardiac output. This is known as cardiogenic shock. Now the question would be, okay, why would the cardiac output drop or decrease, become lower than it should be? There are many causes of cardiogenic shock. Obviously the first is MI, a myocardial infarction. If somebody has a heart attack, then part of their heart has died. That's going to cause a weakening of the heart, a drop in cardiac output, and a corresponding drop in arterial blood pressure. Another thing that could cause cardiogenic shock is congestive heart failure. The definition, you recall, of congestive heart failure is a decreased cardiac output. This is because of a weakening of the heart, commonly caused itself by years, decades of abnormally high arterial blood pressure, and that increased arterial blood pressure increases the strain or workload on the heart, eventually causing a decrease in cardiac output, leading to cardiogenic shock. A third cause is a cardiac arrhythmia. An arrhythmia is an abnormal electrical activity and corresponding abnormal contraction of the heart. There are many types of cardiac arrhythmias that can lead to a decreased ejection of blood by the heart, in other words, a drop in cardiac output and a corresponding drop in arterial blood pressure. Whenever there is a cardiogenic shock, obviously the principal underlying problem is the heart, and the most essential thing is to, if possible, increase or improve cardiac output to correct for cardiogenic shock. Now, the other possibility is a drop in total peripheral resistance. Now, the major factor that physiologically normally affects total peripheral resistance is the overall degree of arteriolar vasoconstriction or vasodilation throughout the entire body. So if there were to be a massive amount of vasodilation, that dilating of blood vessels throughout the entire body would cause a drop in total peripheral resistance and a corresponding drop in arterial blood pressure. The example that we're talking about right here is called anaphylactic shock. Anaphylactic shock is associated with allergic reactions. If somebody is extremely allergic to peanuts, extremely allergic to bee stings, extremely allergic to some medicine such as penicillin, So there is a hypersensitivity reaction resulting in a release of chemical mediators of inflammation throughout the body, including histamine. Now, as we've learned previously, most of these chemical mediators of inflammation that are released from mast cells and other cells throughout the entire body, and most of them cause generalized vasodilation. So there is this massive release of chemical mediators of inflammation, especially histamine, in this hypersensitivity or allergic reaction, leading to generalized vasodilation throughout the entire body, causing a drop in total peripheral resistance, and that drop in total peripheral resistance causes a corresponding drop in the arterial blood pressure. This is sometimes also known as low resistance shock, referring to the fact that the shock or low blood pressure was triggered by a decrease in total peripheral or vascular resistance. Now, the third category that we've mentioned has to do with a drop in blood volume, a drop in blood volume. It is generically referred to as hypovolemic shock. Obviously, one cause of hypovolemic shock would be bleeding, hemorrhaging. Hemorrhaging means to bleed. So if somebody has cut a major blood vessel of their body and the blood is gushing out of their body, that drop in blood volume is going to cause a drop in blood pressure. But it's also possible to have a drop in blood volume without actual bleeding. There are many, many examples of this. This is where there is a drop in plasma volume, a decrease of just the plasma in the bloodstream, not the blood cells themselves. So this can happen with burns and trauma. We have learned previously when somebody burns themselves, this injury to cells causes a release of chemical mediators of inflammation again that cause the wall of the capillaries in the body to become more leaky or more permeable. We all know that if somebody touches a hot object, they may get a blister. A blister is where there is fluid that has left the bloodstream and is accumulated at the site of injury. If somebody had extensive burns throughout their body, so there's fluid coming out of blood vessels all over their body, causing oozing of fluid and a loss of blood volume. We actually learned this a long time ago. And back on page C19, section C, when we're learning about inflammation. So we wrote that when there is injury to the body, that causes chemical mediators are released. These chemical mediators cause a local increase in capillary permeability. Now we know that normally the capillaries of our body are permeable to almost all chemicals in our body, the major exception being the large proteins or plasma proteins. So by the histamine and other chemical mediators making the walls of the capillaries more leaky, proteins in the circulating in the blood start to leak out of the capillaries into the surrounding tissues. As these proteins leak out, they osmotically draw water with them, and as they osmotically draw water out of the bloodstream, that leads to swelling, localized swelling or edema. But notice what that's also doing. It's lowering the amount of fluid in the bloodstream, decreasing the blood volume and leading to a drop in blood pressure. So returning back to page 267, so we simply said that this loss of the plasma proteins and fluid across the capillaries can lead to this decrease in blood volume called hypovolemic shock. Another example of where fluid can leak out of the bloodstream causing a drop in blood volume is related to dehydration. So I'll give you a couple of examples of this. So we have learned previously that somebody with diabetes, in diabetes, their sugar level in their blood becomes so high that these sugars starts to spill over into their urine. That simply means that there's so much glucose or sugar in the bloodstream that as the blood is filtered in the kidneys, some of that sugar starts to flow out of the bloodstream into the urinary system and will be excreted in the urine. And as the sugar is moving from the bloodstream out into the urine, it osmotically draws water with it. This is known as an osmotic diuresis. It is, again, an osmotic effect, not all that different from how proteins dragged water out of the bloodstream into the surrounding tissues, leading to edema in the previous example with shock. In this case, sugar is moving out of the bloodstream and osmotically pulling water with it. That causes a drop in BV, or blood volume, leading to a drop in blood pressure. So again, another example of hypovolemic shock. Hypovolemic shock, a drop in blood pressure. Incidentally, when we did talk about diabetes, that's why we explained that one of the characteristics of diabetes, because of this osmotic diuresis, is a phenomenon called polyuria. Another example of hypovolemic shock is a loss of water from the GI tract. We've actually talked about this previously as well, a long time ago. Any time an individual, especially an infant, is vomiting profusely because they're sick or has diarrhea, in either case, this is really excessive amounts of fluid moving out of the body, either out the mouth in the form of vomiting or out the other end in the form of diarrhea. Now, the question is, if somebody is losing fluid by vomiting or having diarrhea, where's all this fluid coming from? And the answer is it's actually coming out of the bloodstream. We actually learned this a long time ago if we were to look way back on page A2, So way back on page A2, we saw that if this represents the bloodstream and the cardiovascular system, here is the alimentary canal, the mouth end and the anus end. And we saw that not only can chemicals and water that are in the alimentary canal be absorbed from the alimentary canal into the bloodstream, but we saw that there was an arrow going in the reverse direction, that chemicals and water that are in the bloodstream can actually flow back out into the alimentary canal and either be expelled out the mouth end or the anal end. Anytime there is excessive amounts of either vomiting or diarrhea, where all this fluid is coming from is out of the bloodstream, causing a decrease in blood volume and a corresponding drop in blood pressure, again leading to hypovolemic shock. Another example of hypovolemic shock is profuse sweating. If it's somebody is running, they're exercising, it's a hot, humid day, they are sweating profusely. If they are not replacing that water that they are losing in the form of sweat, so the more they sweat, that is causing a drop in their blood volume and a corresponding drop in blood pressure. When somebody is sweating, where is that sweat coming from? The sweat glands are secreting that sweat, and they are getting that fluid out of the bloodstream. So with profuse sweating, there is a corresponding drop in blood volume and a corresponding drop in blood pressure. Another example of hypovolemic shock. Now, no matter what the cause of shock, low blood pressure, the reflex response in the body is similar. So we wrote here that shock is a physiological stress that once again produces reflex responses primarily mediated through the sympathetic division of the autonomic nervous system. We've already learned about the baroreceptor reflex. Whenever there's a drop in blood pressure, the sensory neurons called baroreceptors detect the drop in blood pressure and trigger via the sympathetic autonomic motor neurons. They cause increased heart rate, tachycardia, increased myocardial contractility, venoconstriction, increasing venous return, leading to increased stroke volume. All three of these, of course, lead to an increase in cardiac output. And also the sympathetics cause generalized arteriolar vasoconstriction, which increases total peripheral resistance. Between the increased cardiac output and the increased total peripheral resistance, we get an increase in arterial blood pressure. We therefore see that as there is a decreased flow of blood to most organs of the body, that blood can now be diverted to the vital organs of the body, including the brain. If we now take a look at this diagram on page 268, it shows a fascinating study, an experiment to see what would be the result of the baroreceptor reflex after a 20% decrease in blood volume, leading to hypovolemic shock. So what they did is they had a volunteer and they did the following. First, they measured various conditions or parameters on that individual before they did anything to them. The individual had a resting heart rate of 70 beats a minute, totally normal. Typical resting heart rate is 70-75 beats a minute. The individual had a stroke volume, a resting stroke volume of 75 milliliters per beat. We've learned normally it's about 70 milliliters per beat, totally normal. Cardiac output, remember how that's calculated. Cardiac output is simply the product of heart rate times stroke volume. If you multiply 70 times 75, you get 5,250 milliliters per minute, or 5.25 liters per minute. Totally normal cardiac output. Of that cardiac output, of that 5,250 milliliters of blood being ejected per minute, about 1,300 milliliters of blood is going to the kidneys each minute. That is a totally normal volume. And about 750 milliliters of blood is flowing to the brain each minute. Again, totally normal. What they did next is they very rapidly removed 20% of the person's blood volume. Now remember that normally when somebody donates blood, they take 10% or less of their blood volume. That's about a half a liter. What they did is they took a liter of blood, 20% of this person's blood volume very rapidly. They took a syringe and they immediately measured these very same conditions or parameters after that 20% blood volume loss. At this moment, the heart rate hasn't changed. It's still 70 beats a minute, but that drop in blood volume has caused a drop in the stroke volume. Why? Because removing that blood from a vein decreased venous return. All of a sudden, the heart is receiving significantly much less blood. If it receives less blood, it ejects less blood. So the stroke volume dropped almost by half, from 75 to down to 40 milliliters per beat. The cardiac output, which is simply the product of heart rate times stroke volume, is 40 times 70, 2,800 milliliters per minute. Notice how the cardiac output is almost half of what it should normally be. That drop in cardiac output is going to result in both a decreased flow of blood to the kidney and a decreased flow of blood to the brain. And that's what we see. Of these two, which one concerns us to a greater extent? What concerns us more is the drop in blood flow to the brain, more so than the drop in blood flow to the kidney. What happens next is the initiation of the baroreceptor reflex. The baroreceptors detect this drop in blood pressure and they relay that information to the cardiovascular reflex center. The cardiovascular reflex center activates sympathetic autonomic motor neurons. Sympathetics are going to cause increased heart rate, increased myocardial contractility, generalized venoconstriction, generalized arteriolar vasoconstriction. Let's see the result of that. 5 minutes later, after removing a liter of blood, they remeasure these conditions, these parameters. You will now notice that the heart rate is now 91 beats a minute. So heart rate has speeded up. That's the baroreceptor reflex. The stroke volume has increased, it's improved, it's up from 40 up to 53. It's still less than normal, but it is better. That's occurring by virtue of increased myocardial contractility and venoconstriction, increasing venous return, also increasing myocardial contractility. And so the cardiac output, which is simply, again, the product of heart rate times stroke volume, is now up to 4,775 milliliters per minute. That's still less than normal, but it is significantly much improved compared to what it was immediately after the loss of blood. Now, what's really interesting is you'll notice that here it breaks down blood flow to the kidney and the brain, and it actually shows that blood flow to the kidney is now less than it was when it was measured immediately after the loss of blood. Now, why is the blood flow to the kidney lower than it was even after the blood was removed from the person? The answer is generalized arteriolar vasoconstriction. The constriction of blood vessels to the kidney have even reduced the flow of blood to the kidney now more than it was immediately after the loss of blood. You'd say, well, why do you want to decrease the flow of blood to the kidney? The answer is so that you can increase the flow of blood to the brain. you'll notice that blood flow to the brain has now significantly improved, has gotten better. It's gone from the 500 up to 700. It is almost within the normal level again. This is an example of the baroreceptor reflex compensating for that drop in blood pressure due to the loss of blood. So this shows the amazing ability of the body to correct and compensate via the baroreceptor reflex. On page 269, we want to remind you that after this loss of blood, there would also be hormonal changes. Now, remember that hormonal homeostatic reflexes are slower, unlike the baroreceptor reflex mediated by the nervous system, which occurs in a matter of minutes. These hormonal reflexes are going to occur more slowly. But what's going to happen over the next number of hours and days is there will be a decrease in urine output. This will be caused by both the release of antidiuretic hormone and even more so the activation of the Renin-Angiotensin-Aldosterone reflex. Remember, we've learned that ADH, anti-diuretic hormone, prevents diuresis or urination. It causes urinary retention. In this case, it's not because there's been a change in tonicity, but the very severity of the drop in blood volume has triggered the release of ADH. But even more importantly, there's been activation of the Renin-Angiotensin-Aldosterone reflex, which we know involves the release of aldosterone, increasing both salt and water retention. And this increase in salt and water retention by the kidneys will act to increase that blood volume, improve that blood volume over the next several days. Whatever fluid the person is drinking, instead of being peed out or urinated out, the release of aldosterone will cause the kidneys to retain that salt and water and increase that blood volume, expanding that blood volume. So we see on page 271 that in order to maintain the arterial blood pressure, there is both a homeostatic reflexes involving the nervous system, that's the baroreceptor reflex, and there is also hormonal reflexes to maintain the blood pressure. In the case of the baroreceptor reflex, whenever the blood pressure drops, that activates the sympathetic autonomic motor neurons. The sympathetic autonomic motor neurons cause an increase in heart rate and an increase in myocardial contractility and vasoconstriction, and all of these have the effect of increasing venous return, increasing stroke volume, increasing cardiac output. In addition to the baroreceptor reflex, there is the hormonal mechanism where the drop in blood pressure triggered the release of renin from the kidneys, leading to activation of angiotensin, the release of aldosterone, and the aldosterone increasing blood volume by increasing salt and water retention by the kidneys. There is both a neural and a hormonal homeostatic reflex. Looking at this additional chart on page 271, this provides additional information as far as what is accomplished through the hormonal homeostatic reflexes in compensating after a 1 liter decrease in blood volume. So we see in this chart, before hemorrhage, before removing the 1 liter of blood, this individual had a total blood volume of 5 liters, 5,000 milliliters or 5 liters. Of that 5,000 milliliters, 2,300 milliliters were associated with the volume of red blood cells, and 2,700 is associated with the blood plasma volume, the liquid part. Obviously, that adds up together to form 5,000 milliliters. In this study, you'll recall, they removed 1 liter of blood. That's about 20% blood volume loss. And so immediately after removing that 1 liter of blood, the volume of blood dropped from 5,000 to 4,000. And obviously corresponding decrease in the red blood cell volume and plasma volume associated with that. They then remeasured these volumes 18 hours after the removal of 1 liter of blood. And you'll notice that 18 hours later, the total blood volume has now increased from 4,000, it has increased up to 4,900 milliliters. It is almost back up to the normal volume of 5,000 milliliters. Now, how was that achieved? You'll notice that the red blood cell volume did not increase. It was 1840 immediately after the removal of 1 liter of blood, and that remains at 1,840. But you'll notice that the plasma volume has increased dramatically. In fact, so the plasma volume increased from 2,160, which it was immediately after removing 1 liter of blood, and it has actually increased to 3,060. It is now greater than normal. It has actually become greater than normal. That increase in plasma volume was accomplished through the hormonal mechanisms involving the Renin-Angiotensin-Aldosterone reflex and the of ADH, antidiuretic hormone. Together, they cause the kidneys to retain more salt and water, expanding the plasma volume, and in fact, expanding it even beyond normal to try to bring the total blood volume back towards that 5,000 milliliters which we began with. So we notice that the plasma volume can return quite quickly through largely the retention of salt and water. As far as replacing the red blood cells that have been lost, obviously the red blood cell volume was originally 2,300. It remains still 1,840. It will typically take 2 to 3 months to replace those red blood cells and bring that red blood cell volume back up to the original normal value. So the replacement of red blood cells takes months. However, the replacement of the plasma fluid, that is achieved within a matter of hours.